Hello, everyone, and thank you for joining this active conversation by Diabetes Africa. My name is Greg Trax, and I'm the CEO of Diabetes Africa. As of 30th of April 2020, the African Union Center for Disease Control and Prevention reported approximately 36,800 cases of COVID-19 over the continent and 1,590 deaths. It's worth repeating that no strong evidence base exists to suggest that warmer temperatures will slow the spread of the disease, and the smaller number of confirmed cases across Africa to date may simply indicate that the virus arrived later in some countries. What is certain is that lockdown and social distancing measures have added complexities to healthcare systems already under strain. Patients with diabetes, who are among the most vulnerable to the disease, are at risk of not receiving proper care. This is one of the things that we will discuss today with our panelists. And let me introduce them to you. Dr. Nancy Kunia is a consultant physician endocrinologist. She is currently assistant professor and full-time faculty member of the Aga Khan University Hospital in Nairobi, where she is the head of the Diabetes Endocrine Service. Professor Silver Bahandeka is a senior consultant physician for diabetes and endocrinology at Doctors Plaza Clinic and St. Francis Sambea Hospital in Kampala, Uganda. He is also the chair of the East African Diabetes Study Group and coordinates the management of type 1 diabetes in Uganda, and is an NCD expert advisor to the Ministry of Health in the Ugandan government. And Dr. Sisai Betizazu is an internist and an endocrinologist at Samples Hospital Millennium Medical College in Addis Ababa. He also serves as an assistant professor in the Department of Internal Medicine and Academic and Research Vice Provost. Nancy, for the first question. Nancy, I want us to step back a moment, and I want to ask you, when did you realize that COVID-19 was going to have a lasting impact on your activities?
We had our first case reported in Nairobi around the 13th of March. And I think the week after, the Kenya government responded rather fast. And when the lockdowns and the decisions on flights were made and began to start to be being made, that's when I realized our practice, something would change. So I think it was a week after our first case that I started getting a sense that things would be different.
Yes, okay. So when the WHO first declared that COVID-19 is a public health emergency of international significance in 13th of January, we get the alert. But we found the first case on the 13th of March, and that was close to 7 weeks back, and that was a Friday. So on Monday, so the government closed the schools. So within my hospital, so we have established a task force, and on the same week, I think we have designed some strategies, like we started to triage patients, and we have made also some service rearrangement. That is at the time when we have noticed that it is going to be, COVID is going to have a significant impact in our health system. And at that time, one of the actions that we took was, so in order to reduce crowding, we have minimized our outpatient patient flows, so non-emergency patient flows as well as non-emergency surgical. But we decided to keep our non-communicable disease chronic care clinics open. So it is at that around that time that we have started to take it seriously.
And Silver, what about Uganda? What is the situation, and what measures have been taken from your place of work to address the epidemic?
We had a lockdown about 3 or 4 weeks ago, and most of our cases have been imported cases. So we haven't had a serious issue within the country as such, and the numbers have remained low, and we pray that the numbers remain low. Most of our population is in the rural area, So they were the ones we were worried about because they may be difficult to access if they are going to travel a long distance to get to the health facilities. But the system that happened is that the first partial closure allowed us to be able to send supplies to most of the clinics, and we were concerned about the type 1s who would otherwise get into ketoacidosis very easily. So those ones we were able to access because we operate electronic healthcare records, and they have a stock in, a stock out. So the health centers were able to tell which one had a limited supply, and we increased the supply. And secondly, we also advised our health workers to give a little more supply of insulin than normally we give, and to advise the patients that the clinics will remain open despite that there were going to be lockdowns. So the local authorities would allow the patients to go and access their insulin. So that was with regard to the type 1s whom we were really worried about. And the type 1s, again, were able to send automated SMS messages that the clinics continue to run and they should access the health facilities as and when they require to do so. Or if they are not able to move, they send an SMS message. So we've had to rely mainly on the digital system, and the digital system has been quite useful. And then the rest of the hospitals have had their supplies. Of course, the fear has been there that, the hospitals may close and patients may not be there. But most of the places have been open and running. And as I said, we haven't had cases of requiring admission within the community. So the fear has been generally low. And secondly, most of our messages come from the radio and the phones. The TV, it's only about 34% of the Ugandans who access the TV. So the fears which they get from other places have been relatively low.
What have been the measures that have been taken from your point of view, Nancy?
Talk about, I think, government measures is what has been done in policy. And I think very quickly, the ministry, together with the medical practitioners and dentists council and various bodies, Kenya Medical Association, WHO representatives, and a wide group of people came together to put together the strategy. In terms of government initiatives, they've been school and college closures. Those happened quite early. And what we have more recently is a curfew and restriction of movement in certain areas where there has been some community spread. So Nairobi, Mombasa area, and you cannot come now into Nairobi without some justifiable reason. So we've had some containment decisions, and then like in our practice, what happened was start to put together a team that did both education for healthcare workers, think about PPE, isolation, and they've been great efforts. We are collaborating both private and public sector as far as isolation facilities and where you can have centralized places where patients are being taken care of.
You've mentioned restriction of movements. How has this affected access to care and access to medicine?
So access to care has been interesting because within the clinic and medical setups, what we've tried to do is, first, we have set up some telemedicine, which is new and an interesting initiative across a number of hospitals. And then is triage, as I think my colleague has said, and think about who needs to come to the hospital and when they need to come in, especially for chronic care. Access, of course, has been affected by the curfews because of movement within, especially for people outside of the Nairobi CBD. And I think there were efforts to just think about that whole triage system. I think the individual, the fear that patients also had changed health-seeking patterns in some senses. So that has been interesting. Initially, people naturally did not come to the hospital. They were worried they'd be infected there. But that trend has changed a little as people with diabetes think that they might be high risk and therefore want to have care.
One of the response that was taken by the government, the federal ministry, was to identify some hospitals who will be repurposed fully or partially to serve as a COVID treatment centers. So that one of the hospitals that was selected for that purpose was our hospital. So we dedicated one building and we are repurposing it for COVID-19 treatment center. So as part of that, so we need to reduce our routine activity, but we decided to maintain our non-communicable disease follow-up care. But because of the international as well as the trans-regional travel restriction within the country, so we were not sure how significantly the supply chain of medications and testing strips will be affected. So we have redesigned our non-communicable disease follow-up clinic in such a way that we will have a longer clinical visit for our patients, but we will have a shorter pharmacy refilling visits. But even if we keep our non-communicable disease, including diabetic follow-up clinics open, so we have seen a significantly reduced number of patients. For one, so as Nancy already said, so patients by themselves, so they have changed their healthcare seeking behavior. They thought they will be infected when they visit the hospitals. And the other is, so there was also some miscommunication by the media about the rearrangement of the services. Something that, so we are fully a COVID treatment center. And the other is the trans-regional transportation ban. So that also affected our services significantly.
We started the central registry several years back, actually about 9 years ago. And we never, of course, anticipated having COVID at all. And I hope we don't get it anyway. And the system is that it uses a web-based electronic healthcare records. And we have a central registry on it. Can operate as an offline. Each health worker has a password limited to the patients they normally see. If for some reason another patient goes there, then the health worker contacts the admin and the admin can give a password to access a patient who has migrated from one area to that area. So that is for confidentiality purposes. But the application has helped us in several ways now, in that we have been able to detect the stock in, stock out. And secondly, we have used it to give automated messages so that the patients are aware the clinics have been running. And thirdly, the third measure we put in was to have a stepwise approach by the administrator, by program manager, to check on the centers that are maybe running low. And those then we ask the government, the government to help in moving insulin. Like recently, patients were moving from Jinja, which is about 50-60 kilometers to the center to get their insulin. And that would be too long in a lockdown. So the administrator in Jinja sent a vehicle, and all the patients then in Jinja will get their insulin from the nearest locality. So that in that way, we have been able to track who is running low and who is not running low. And then thirdly, in areas which are not easily accessible by cars, we have been able to employ motorcycles, which we call boda boda here. And the boda boda then can easily distribute the insulin from a central supply to the patient so that the patients don't have to move. And this has worked very well in the cities. and but in the rural areas we haven't had any issues so far. What we are still, of course, concerned about is that patients still fear to move, and the fear that hospitals may contain infection is real. And they even fear the medical workers themselves, because the news from outside is that the medical workers get infected first and they may transmit the disease to the patients. So that has been there. And we reassure them, please take the precautions with anyone as they come. So that is how we've been managing the lockdown. For the type 2s and the other non-communicable diseases, the health facilities have remained open. Health workers have permits to move. With the identity cards, they are enough, and they can drive to their places. Inevitably, there is reduced transport, so you'll find that the facilities are no longer as active as they used to be. So there is some effect. Regular follow-up is, of course, not taking place. We are just about a month of no proper regular follow-up and no checks, and that is inevitable in this sort of situation.
Nancy, what similarities did you find with what the situation in Uganda is, and between Uganda and Kenya? Can you react to what was said by Silver?
Yes, I think there are some similarities and some differences, because our country, we have a devolved government structure. So a lot is being done at the county level. So there's a centralized body called KEMSA, which is responsible for medication supplies. And then at the county level, then that goes down into the populations. There have been about over 50,000 healthcare workers trained on COVID and the whole response. And that has helped in the different counties then to allow patient contact even in the rural areas. So I think the county system, in terms of tracking, in terms of even infection, in terms of the who has type 1 diabetes is a plus as far as access to care is concerned. We have also in certain areas in Kenya what we call centers of excellence, and those are focused on just supply of and care, or the routine care of persons with type 1 diabetes. We have not used much of the border system, but that would be happening, I assume, at county level rather than from the Nairobi outward. So the county structure system has been a target as far as training is concerned, and provision of care and healthcare worker training.
It will be very difficult for me to tell about the whole national response in relation to type 1. So I think I know of efforts made by the Ethiopian Diabetic Association. But when it comes to our follow-up in our the type 1s in our hospitals, so at least for those who are residing in the city or in the nearby areas, so they will have, so far we don't have significant problem with the supply chain, be it for insulin or for oral anti-diabetic drugs. But we don't have an electronic medical record tracking, unlike Silver's mentioned for Uganda. So, but we are using at least mobile phone to have an online consultation, offline consultation with our patients, be it for supplies as well as for the clinical consultation.
The other topic I wanted to cover with you is telemedicine. We've touched on it. Can you describe in your particular circumstances what telemedicine has meant, whether it's a relationship with patients via phone or video, or different ways to reach out to patients?
Okay, so I think the initial response was quite quick as far as just thinking about how to structure care to our patients. And telemedicine in Kenya, because we are a highly, we have a very high utilization of mobile technology in Kenya, even in the rural areas. is almost a natural way to do it. So we have done it in different ways. There are people using apps and hospitals and clinics using formal apps that patients can log into and ask about general medical issues. And then for the specialists, in my experience, we have used the mobile telephone in actual telephone conversations with patients. Second is the use of Zoom, even for appointment structures. So you still sit in your home or in an office and actually book in the patients and have your 10-minute conversation with them. At our facility, what we are doing is actually you have those conversations, do your telephone, you do your prescriptions and email them and send them over to the patients. What is interesting in Kenya also has been a lot of home delivery options for both medications and the lab facilities. So that has grown a lot in this COVID time and has been very interesting to see how it's used and will probably be there post-COVID. So a lot of innovations in care and access to care for those at home especially.
So as Nancy said, so phone, the coverage is high, so I think that is a good option for us as well. So for individual consultation, we have been using it also. And from the hospital perspective, we are also reactivating our 3-digit toll-free call center. So we are using part of it for the COVID response. We are planning also to use the rest for patient appointments and patients consultation, especially clinical consultation. But for the internet coverage, because of the internet penetration is so low, it might be a good option for all patients, especially for those who are coming from the rural side. Otherwise, mobile phone as well as these toll-free 3-digit numbers, so that are good options for us as well. And as Nancy also said, so we are trying to explore also ways of delivering for in the phone or in the mobile, in the internet. What we can address is about the clinical consultation. But for the supply chain management, I think we need to use also the community health workers, the health extension workers, and we have to communicate with them also through the phone or text message, as well as using social media so that we can send the prescription so they can distribute the medication based on the virtual prescriptions. For it's the mobile phone is something that we are using now, but the other is still possibilities that we are exploring. We have not yet started to implement.
Yes, if I can come in a little for a little bit of a difference on using phones and SMS messages for Uganda, is that we advise patients to see their nearest health worker. And then because we are much more used to the patients than the health worker they may be seeing, is that we advise that when they reach the health worker, then they can tell the health worker that so-and-so has been looking after me. Would you want to get much more information? And that's how the system has been. We have been rather reluctant to give straightforward prescriptions to patients without seeing them because it has a little wider implications on that. So we normally advise them to see the nearest health worker, even if it's a nurse, so that the nurse can give you the real picture that is there, and then an advice can be taken on.
Obvious challenges with telemedicine on terms of course, legal data protection, confidentiality. But we have found if you have some form of a triage system in terms of just asking the patient, do you really need to be in the hospital? What are the symptoms? There are people who are still coming for face-to-face consultation, so the hospitals aren't completely closed out to them. But for routine care, we have found the telemedicine is actually quite interesting and working and is just gaining some a lot of momentum even for patient preference.
Nancy, we had Eva on the chat mentioning a program called Fafanuka, which I assume is sort of a precursor to the discussions or the to reaching out to patients over the phone. You aware of this system?
To communicate with the patients on mobile technology. And I think a lot has been done in Kenya as far as education, especially on awareness, not just in the COVID time, but also for diabetes and access to information on diabetes care. One of the things I have noticed in clinical care has been a greater awareness that because we have said people with diabetes are at higher risk, especially if not well controlled. We have had a number of like our study group put out a statement for patient care, and a few other groups have done that. And there is an increasing awareness of the need for better control. So that has been interesting, seeing both people with new diabetes and people who are not well controlled now seeking to take better care of themselves to prevent COVID infection.
I just wanted to ask Sisai if you could react to what Nancy has said with regard to patients being more careful during COVID about their monitoring. Have you observed this as well?
Yes, I concur also with her. So there are the few patients that are coming to the clinic, so their awareness as well as their willingness also for treatment intensification as well as for adequate glycemic control is higher, as well as their adherence to the preventive measures for COVID, as well as they're the one who frequently utilizes the sanitizer, the face mask, social distancing. I think, yeah, so I'm not sure how much, so is it generally in all diabetic patients, but I think most of the patients that are visiting our clinics, so we have seen also similar trends, positive development.
And Silver, from your side, patient behavior, what changes have you observed?
Yes, we've of recent, of course, my phone rings almost every 5 minutes with patients asking about, I've checked my blood glucose, it's a little higher, and so forth. So they are taking a little more care than they used to do before, but that's natural in such a disaster. The family now much more caring than they used to do before. They would leave actually the older child to go and correct their medicines, despite telling them, please come accompanying the child. They would say, go and prick your insulin, we shall solve the remaining things later. Now you actually see much more cohesiveness, people want to understand and so forth. But I think that's a natural behavior when there is a disaster. Whether this will change the behavior to continue remains the health workers to really interpret. And probably we should hammer it on that, look, this can be done. And if they are done during such a serious problem, why don't we do them under normal conditions? But this is human behavior. I cannot predict what is going to happen.
Very, very well. Thank you, Silver. I want to move on to the question of risks, because we had a comment from one of the participants, Kennedy Odoconero, who was, he is a student in pharmaceuticals and health supplies management in Uganda, and saying that he's observed that prices have gone up in private pharmacies. These have started happening before the lockdown. Pharmacies in Kampala are doing home deliveries, which drive the costs further up. The risks are not unique to insulin, but for all medicines, and that hoarding has also led to an increase in prices. Is this something that you are concerned about? What other consequences related to diabetes care and access to medicine are you worried about? Can I start with you, Silver? Are you worried at all?
I'm not worried at all, because this is, as I said, it's human behavior. The president himself has said to the Ugandans that those who are hoarding food, for example, if he gets them, they will be punished. But that is even, it has gone as far as food. Now the price of food has gone down because nobody's buying it. We are talking about the local food matoke. Nobody's buying much of matoke. To me, I think this is human behavior. It's reactionary behavior. As far as insulin is concerned, I don't think the price of insulin will go up because we have sufficient supply. That is number one. Number two is I've been informed WHO has donated more supply of insulin. Of course, if you order the insulin by a border to pick it and bring it back, it will sound more costly. The cost will go up. But then one must put in, factor in or other things that have been going on. How long is this going to stay? I don't think, from my point of view, speaking from Uganda, I don't think it's going to be for long because the indications are that they are going to open, and those who have been hoarding drugs will have to give them at the price they used to be before. So I think, as I said, it's human behavior. It's difficult to get a pharmacist and say, look, why have you put up this, the cost of this drug? But in general, I don't think I'd be worried that someone is going to miss his drugs. Of course, the costs of COVID are much more than we are seeing on the ground. People have lost their jobs, the income is low, and in most developing countries in sub-Saharan Africa, the problem has been paying out of the pocket, causing family to go into severe bankruptcy. And that has been the discussion that we have been having at all of our fora. Paying out of pocket is a barrier to accessing care. And it's made worse by the COVID. So that is something that we hope governments will have a look at. Hasn't got a single solution, but it's something to be aware about.
Do you have any concerns, or do you foresee any risks if the situation extends into the future?
Yes, I'm really seriously worried about the interruption in the supply chain management, both because of the travel restriction internationally, because we import most of the medication, including insulin, as well as the interruption or disruption in the supply chain in country. So unless it is proactively made, so definitely there will be distraction. There will be more focus on COVID-related PPEs or medications or medical equipment. So I'm really worried. Currently, we are not seeing that much significant problem in this access to medicine, at least for our patients. But I'm really worried about it. And the other is, in addition to access to treatment, so if these restrictions continue for so long, so I see also issues in diabetic control, particularly its effect on physical activity, as well as availability of fresh vegetables and the likes, as well as the stress that it causes also. Because diabetic patients, we have said that because they know that they are at higher risk, so it causes a positive response for adequate glycemic control, opting for an adequate glycemic control, but it puts also them on a lot of stress. So it might cause also it might also have effect on their blood glucose control, or in general in their diabetic control. So these things are really worry me.
I think economics and purchasing power is what might be a game changer when income earnings drop or people are being laid off. And because we don't have, everything is not fully funded by government, people pay for a lot of medications out of pocket. So I think that purchasing power is going to be a challenge in the long run if the restrictions remain very long. I wanted to just comment on something on physical activity. I have noticed though that people are walking and doing a little more walking around estates and things like that, or doing a bit more exercise because they are home. So I've found that an interesting observation, even when you're out on the streets or going to work. They are social distancing, but also doing a bit more walking in communities, at least in the urban area, which I have found quite interesting.
Yeah, but one thing that I have noticed is for diabetic patients, because they took social distancing so strictly that they will not come out of their house. But in general, as you have said, so you see a lot of people walking or jogging early in the morning. But from my conversation with diabetic patients, so they are opting for the social distancing more than for the physical activity. I think that is something that we should be encourage them to do.
A question to you all, because this was mentioned in the chat. Have you seen a negative impact on the mental health due to the lockdown and isolation of patients? You mentioned that, Sisai, you mentioned that people were likely to go out maybe or walk when they could. Have there been also, have you seen patients affected negatively, particularly with regard to mental health, and then having difficulties adhering to their treatment? Is there any one of you who wants to respond to that?
Yes, if I may respond to Uganda, I think this is much more of an imported, I would say an vision. Because if you come to Uganda, I don't know exactly what is happening in Kenya and Ethiopia. People are really not locked inside their houses. We should remember that, as I said, 75% of most of our population live in the rural area, and they are actually out busy digging and moving around. So they are not really locked in. It's only the ones in the city, and even those in the city, we don't live in skyscrapers in our countries. So most of the people, if they live in flats, okay, they may be locked in, and we are talking of a very small minority, and I don't think yet we have figures, and the time has been so short to start talking about mental illness. We may be able to get it, and we have to really need evidence for that. But as I've been going to the out of the house where I stay, and I live in the city center, and there are people walking on the roads quite well. They're social distancing fine, but they are walking on the roads. And recently, our president had to get out and tell them, look, do your exercises inside the house, because the whole street was instead full of people exercising. So in our East Africa, at least, I don't think people are locked inside at all. They live in the villages, and in the villages, there hasn't been a lockdown. Like, I don't see how you lock down somebody on 6 acres of land.
I think the people who would be struggling now is the slum area and the highly congested. And I know one of the things that has been a concern for mental health has been children and playing, and what that is doing, because the schools are closed and children are inside. What's that doing to the long-term mental health of even younger children? We're talking about under 10s. And second, I think domestic violence has gone up a bit from some of the groups that have said that, because of men being in homes earlier and in crowded homes, and just the stress of being with families and children and hard economics. So those are the two areas, I think, right now that have been reported upfront early on in this scenario.
Yeah, so it's not only the restriction or isolation or social distancing, it's also the economic impact also will have a significant impact on their mental health. So this is something that we are not systematically assessing, but we are seeing case by cases, especially for those patients, those individuals who are on quarantine or in isolation, or those with families who is in isolation. But I think this is something that we should keep an open eye and look for it, both because of the social restriction as well as the economic impact. So this is something that we should actively look for.
Would you have a message to share with policymakers with regard to COVID-19 and diabetes? Can I maybe start with, Sisai?
Yes, so I think one thing that everybody needs to consider is we shouldn't substitute the course of days. So we shouldn't let people with non-communicable disease to die while we are trying to save lives from COVID. So I think that is something that we should emphasize to the policymakers. So in our places, for instance, in the initial reaction was to refocus most of our activities to COVID related. But after 2 weeks, we have realized that we are neglecting a significant number of our patients who are susceptible to significant morbidity and mortality if we are not providing them proper care. So I think that thing has to be emphasized. So now it seems that the government is also emphasizing on that. So the other is, so as I have already said, so the mental health issues as well as the supply chains needs to be addressed, particularly for patients who are on non-communicable diseases, including diabetes.
Of course, priorities remain priorities, but as soon as the COVID situation seems to lessen down, I think government has to look at the impact COVID will have had on that the out-of-pocket is definitely going to burn them off. It will cause serious family bankruptcy, and they need to be helped out in that regard. So there is need for more funding, a closer look at out of the pocket for medicines and other supplies for patients with chronic illnesses.
Some of my points have been said about thinking about other illnesses apart from COVID, because as much as we are concerned about it, it's not the biggest problem we are having right now in terms of healthcare. We still have other chronic diseases, stroke, and so many other, hypertension and other challenges. I think food security is another thing to think about in hard economics. We've had locusts recently in East Africa. So when economics are hit, and we've been focusing on also on healthcare access for workers, our food security is something to think about as we are facing a more challenging economic times. And then the mental health of healthcare providers in the long run, and what will COVID do to the healthcare industry, and how will it shift after this has passed?
We are planning, obviously, to summarize some of these discussions. If I could ask everyone at home or at work looking at this to give our panelists a round of applause. You will not hear them, but I'm sure that they will be doing it. We've got a couple more questions for the participants. So before leaving, if you could answer the questions that we are putting on the poll, which is the focus of the next webinar, and also whether you would recommend this type of discussion to colleagues or friends. Once again, I'd like to thank you, Professor Nancy Kania from the Kenya Diabetes Study Group, Professor Silver Bahendeka from the East Africa Diabetes Study Group, and Professor Susai Petizazu from Temple Hospital Millennium Medical College in Ethiopia for joining us. We very much look forward to the opportunity of working together towards improving diabetes care in Africa. And until then, thank you for joining us, and we look forward to hearing you, speaking with you, and seeing you very soon. Thank you.
Thank you.
Thank you.
Thank you
Greg,
very much.
for having us, and thank
Good
you to the
evening.
team.
Thank you.
Thank you.
Bye.
Thank you.